Jacob. I'm a final year medical student at Lancaster Medical School. Welcome to part one of this gastroenterology series, where today we're going to be talking about alcohol metabolism and liver cirrhosis. So with that being said, let's get straight into the video. So first of all, I'd like to talk about alcohol pharmacokinetics, so how the body responds to alcohol. And as you may already know, within pharmacokinetics, we look at four different aspects. So we look at the absorption, distribution, metabolism, and excretion when we're talking about drugs. Okay, so generally speaking, alcohol's slowly absorbed from the stomach, and it's more rapidly absorbed from the small intestine. Alcohol's also water soluble, and that means that it doesn't enter fat. Okay, so like I said, it's slowly absorbed in the stomach via the paracellular route, so not into cells. It's between cells essentially, and the absorption is slowed by food, particularly carbohydrates. Absorption is also faster when when alcohol is carbonated. So if you've ever drank champagne, you tend to feel the effects more quickly because of that carbonation. Let's talk about distribution. So alcohol has a volume of distribution 0.5 to 0.7 liters per kilogram. So that kind of relates to the degree of which alcohol is distributed within body tissue. I've already mentioned that it's water soluble, and then the liver has the most exposure to alcohol because of the portal system. And alcohol generally diffuses into organs slowly, except organs with a rich blood supply, such as the brain and lungs. We'll go into detail more about metabolism very soon, but essentially there are two enzyme systems. So we have alcohol dehydrogenase, which also uses a coenzyme called NAD. NAD stands for nicotinamide adenine dinucleotide. And we have another enzyme system, CYP450-2E1. So 2E1 is the specific enzyme, and the CYP450 is the group of enzymes within the liver. So CYP stands for cytochrome P450, and 2E1 is the particular enzyme within that group, and that utilizes an enzyme called NADPH. So it's still the same as NAD, but you also have the additional P, which stands for phosphate, and the H essentially means that it's reduced. So let's talk about excretion, so how the body gets rid of the metabolites. So this is mainly through breath, urine, and sweat. Alcohol also inhibits antidiuretic hormone secretion. Therefore, if you've ever drank alcohol before, you'll notice that you go to the toilet more frequently. So there's more frequent urination. Alcohol is typically excreted as acetic acid, and you'll understand that a bit more later in the video. And sometimes these enzyme systems, particularly the alcohol dehydrogenase enzyme, can become overwhelmed, and alcohol has to be metabolized via, or more so via, this CYP450-2E1 enzyme, and that can have its own associated problems, which we're going to talk about. Okay, so this is essentially going to be an explanation of alcoholic fatty liver disease pathophysiology, and like I mentioned previously, the CYP450-2E1 enzyme is massively upregulated in chronic alcohol use, and this is because the alcohol dehydrogenase enzyme, the other enzyme, can become saturated, so the body has to use other systems in order to metabolize the alcohol. Okay, so let's work through this logically. So we have ethanol coming in, and this cell here, by the way, is a hepatocyte. So a hepatocyte, which makes up the active tissue of the liver. So ethanol can be converted to acetaldehyde, and this is done via the enzyme alcohol dehydrogenase. And in doing so, the coenzyme NAD is reduced, and you have formation of reduced NAD. And like I said, if the system becomes saturated, um, the ethanol can also be converted to acetaldehyde via the CYP450 system. However, if it utilizes this system, it can create lots of dangerous oxygen-free radicals, which can cause DNA damage and mutations. Acetaldehyde by itself is also known to be carcinogenic and can also cause DNA damage and mutations. So then acetaldehyde is converted to acetate, and this is done via acetaldehyde dehydrogenase. And again, NAD is converted to reduced NAD, which is otherwise known as NADH. Acetate is then converted to acetyl-CoA. So we've had the addition of coenzyme A, which utilizes the enzyme acetyltransferase. Acetyl-CoA is then converted to fatty acids. But in this step of the process, instead of NAD being converted to reduced NAD, we're going to have reduced NAD being converted to NAD. So it's the opposite at this stage. And then the fatty acids tend to be stored as triglycerides. So this is what TG stands for. So you get an increase in the number of triglycerides within the hepatocytes. And when you have fatty liver disease and you do an ultrasound scan, for example, you might have these hyperechoic areas which represent the increased density of triglycerides. Okay, so this essentially illustrates that ethanol, acetaldehyde, and acetate all can enter the systemic circulation, particularly ethanol and acetaldehyde, when the enzyme systems become overwhelmed within the liver cells. So the ethanol and acetaldehyde, which remember is carcinogenic, can enter the systemic circulation. And when we have excess alcohol consumption, like I said, we have an accumulation of ethanol, acetaldehyde, and reduced NAD in the liver and also in the bloodstream. In terms of reduced, when we have elevated levels of reduced NAD, this inhibits glycolysis, which means that glucose isn't converted to pyruvate. This leads to a buildup of glucose in cells, and this can result in hyperglycemia. So if we come back to this diagram, and we've got lots of reduced NADH being produced. We've got lots of reduced NAD being produced. This system is going to be saturated, and therefore the only ways to utilize reduced NAD is to convert acetyl-CoA to fatty acids, which are stored as triglycerides, which we don't want because then that's going to increase the fat content within the hepatocytes. And then also we have this process where it's inhibiting glycolysis, which normally requires phosphorylation and oxidation, which ultimately can result in hyperglycemia. So if we look at acetaldehyde now, we know that it's carcinogenic. It's highly reactive. It's highly reactive and unstable. So that should say reactive, and that can result in DNA, protein, and also enzyme damage. Acetaldehyde also activates hepatic stellate cells, so star-shaped cells, which then release a substance called tumor necrosis factor alpha and also collagen. When you've got lots of collagen being released, this can ultimately lead to something called portal hypertension, which we're also going to discuss in more detail. Stellate cells, they're normally quiescent, so they normally um, don't have an active function, and they store vitamin A. And like I said, they're activated by inflammatory cytokines and elevated acetaldehyde levels. And they also release inflammatory cytokines. And I just want to reiterate that they produce the collagen, and this can contribute to fibrosis and ultimately liver cirrhosis. Acetaldehyde also upregulates the production of enzymes required for fatty acid synthesis, um, and it also contributes to hepatocellular carcinoma. Tumor necrosis factor alpha stimulates systemic lipolysis, fat production in the liver, and also production of reactive oxygen species, which is all adding to this fatty inflammatory process. And the reactive oxygen species damage the mitochondria. Therefore, we've got less beta oxidation, so we've got less fatty acids being converted into acetate. So we've got this continuous buildup of fatty acids. And if a person is obese, this can further contribute to the pathophysiology of alcoholic fatty liver disease. And when we ultimately have cirrhosis, so irreversible scarring, there's a risk of hepatocellular cancer, liver cancer, and we're going to talk more about how you can monitor a patient's risk of that developing. Overall, in terms of this process, there's an increase in fatty acid synthesis and a decrease in beta oxidation, remember, because of that mitochondrial damage. There's an increase in inflammation and steatosis, so fatty change to the liver. Therefore, there's an increase in fibrosis and therefore ultimately cirrhosis. Fibrosis is reversible scarring of liver tissue. Cirrhosis is irreversible scarring of liver tissue. And the hepatic cell regeneration is restricted, and it typically forms nodules. And in histopathology, when pathologists typically describe the liver tissue as having this micronodular pattern. Okay, so let's talk about some clinical features of cirrhosis, and also about the mechanisms which lead to the clinical features arising. So first, we're going to look at portal hypertension, what that results in. So portal hypertension is an increase in the pressure within the hepatic circulation. We have a backup of blood into the collateral venous system. And this can result in something called caput medusae, which is where you have dilation of the para-umbilical veins. And this can be described as being snake-like. You have an image here you can see. So we have this dilation of the para-umbilical veins. Also, because of a backup of blood into the venous system, you can have this murmur called Reveille Baumgarten sign, which is a murmur within the para-umbilical veins, which can be heard on auscultation. Also, blood can back up into the spleen, causing enlargement of the spleen, otherwise known as splenomegaly. And then if you percuss over Traub space, there can be dullness if splenomegaly is present. And Traub space is essentially an area bordered by the left anterior axillary line, the sixth rib, and the costal margin. Dullness suggests splenomegaly, and if the sound is resonant on percussion, that could suggest air within the stomach. And also, for splenomegaly, you might be able to palpate the splenic edge in the left upper quadrant. So normally the spleen shouldn't extend below the costal margin. If it does, you might be able to feel that border. Okay. So because of portal hypertension 2, we have an increase in the hydrostatic pressure within abdominal capillaries, which can result in fluid moving from the plasma in the capillaries into the peritoneal cavity. We know that the peritoneal cavity is the space between the parietal, the outer, Parietal means like out of the wall, and the visceral peritoneum. This can result in ascites. So ascites is this fluid accumulation within that peritoneal cavity. And when we have ascites, we might have signs such as shifting dullness, and there might also be a positive fluid thrill. We can see this is an ascitic abdomen. It's very distended. Okay, so these are some of the clinical features of cirrhosis, which occur due to unknown mechanisms. So we can have clubbing of the fingertips, and you can examine this by doing something called Shamroth's window test, where you essentially put the nail beds of your two index fingers together, and there should be a diamond-shaped gap in between the fingernails, and if there isn't, that could suggest clubbing. We have a nice image here of some clubbed fingers, fingertips in particular. And clubbing can actually be seen in other systemic disease, such as infective endocarditis, lung cancer, can also be seen with more infective etiologies, such as tuberculosis. The second thing we tend to have in cirrhosis is pruritus, which simply means itching. Can also develop Dupuytren's contracture, and that's a particular sign seen in alcoholics. We can kind of see it here, and essentially what this is, it's palmar fibromatosis, which results in almost like a contracture of the little and ring fingers typically, and it's also associated with quite a high association with diabetes too. And we also have this sign called Terry's nails, and essentially Terry's nails are a subtype of leukonychia. And if you were to examine someone with Terry's nails, they'd appear white with a reddish brown tip. And the mechanism isn't, like for all of these signs, isn't fully understood. But in leukonychia in particular, it's known that there's an association with low albumin, but this isn't quite the same thing. It's a subtype. So let's talk about some of the clinical features of cirrhosis related to liver insufficiency or reduced liver function. So the liver has a reduced ability to synthesize clotting factors. That means there's a reduced clotting ability of the blood. This is going to result in a coagulopathy, otherwise known as the patient's going to have bruise easily, essentially. There's a decreased ability of the liver to metabolize estrogen. So you're going to have elevated levels of estrogen, which results in arteriolar dilation. This can result in signs such as spider nevi and palmar erythema. So here we have a spider nevus, and in alcoholic liver cirrhosis, you can typically find these on the chest area, and you might see maybe roughly 3 to 5 separate nevi. We also have an image here of palmar erythema, so red palms. High estrogen can also result in gynecomastia, so in males, development of breast tissue and also testicular atrophy. So here we can see we have some gynecomastia. The liver also has a reduced ability to metabolize waste products, particularly ammonia. This can result in a phenomenon called hepatic encephalopathy, which can result in something called asterixis, which is jerking movements, typically of the outstretched hands on examination. The liver is also going to fail to secrete conjugated bilirubin. So there's going to be an increase in systemic bilirubin, and there's going to be increased deposition within the dermis and the sclera, so the white of the eye. It's going to result in scleral jaundice and also jaundice of the skin. And this image here demonstrates scleral jaundice. Okay, so let's talk about the complications of cirrhosis. So here's a reminder of the definition here. So we know it's irreversible scarring of liver tissue. Means that hepatic cell regeneration is restricted to form nodules. Remember that micronodular pattern in alcoholics in particular. And here it's going to be essentially a schematic of the complications which can occur. So we have portal hypertension. Remember, because we have that increased collagen connective tissue production by the stellate cells, which can create increased resistance within that portal venous system. And portal hypertension is particularly when the pressure is greater than 6 millimeters of mercury. Remember, it's a venous system. We can have these portosystemic shunts. And portosystemic shunts are essentially connections between the portal system and the systemic venous system. So when we have the left gastric vein, this can connect with the portal venous system and can ultimately result in varices. You can then end up with a variceal bleed. Remember, varices could be classed as esophageal varices. You could also have hemorrhoids, which are dilated rectal veins, which are also another form of varices. And then also we can have backflow of blood into the spleen, which can result in splenomegaly, so that's splenic enlargement. When we have splenic enlargement, the spleen can trap blood cells, resulting in anemia and thrombocytopenia, so low platelets. You can also add to that easy bruising which the patient might experience. So also a result of portal hypertension, there's vascular stretch, and we have nitric oxide release, which is a vasodilator. So nitric oxide enters the systemic circulation, which results in pulmonary vasodilation, so vasodilation of the pulmonary vessels. This means that there's increased flow within them vessels and reduced time for gas exchange, resulting in something called hepatopulmonary syndrome, which can present with dyspnea, hypoxia, and it's also worse when the patient's upright. This is quite a rare complication of cirrhosis, though. Okay, so when we have the nitric oxide entering the systemic circulation, the kidneys, because it's a vasodilator, can think that there's a decrease in the effective arterial blood volume. So the kidneys then retain more sodium and water, and there's going to be a net fluid movement from the vessels into the interstitial space, which is going to result in ascites. So remember that abdominal accumulation of fluid within the peritoneal cavity, and also peripheral edema. And this can also be potentiated by another process due to liver insufficiency, which we're going to mention in a second. So we can also have hepatocytes, or liver cell dysfunction, which results in decreased albumin synthesis. So albumin is a protein important for maintaining oncotic pressure within postcapillary venules, so that fluid returns into the circulation and doesn't remain in the tissue. So because there's decreased albumin synthesis, there's a decrease in capillary oncotic pressure, and therefore there's going to be more net fluid movement from the vasculature into the interstitial space, further contributing to the ascites and the peripheral edema. We also have a decrease in the synthesis of clotting factors and anticoagulants, so naturally produced anticoagulants such as protein C and S. There's typically a variable balance of coagulation and anticoagulant factors. So there may be an elevated internalized normal ratio, plus or minus a coagulopathy. So I've decreased metabolism of waste products, which we've mentioned, particularly ammonia. That's going to accumulate and cross the blood-brain barrier and result in that hepatic encephalopathy. There's decreased conjugation of bilirubin and secretion of bilirubin into the ducts, into the hepatic ducts. Therefore, when serum bilirubin is greater than 30 micromoles per litre, this can result in jaundice. Okay. And essentially, in hepatopulmonary syndrome 2, so the reasons is because there's an increased flow within the vessels. There's also mixing of arterial and venous blood. All kind of add into this decreased time for gas exchange. And other complications which can result from cirrhosis, such as the first one's related to the hepatocyte dysfunction, because there's reduced hepatic thrombopoietin production. So thrombopoietin stimulates platelet production. If that's reduced, there's going to be less platelets produced. You can also have cardiac problems such as cirrhotic cardiomyopathy, which tends to be hypertrophic. Another renal complication called hepatorenal syndrome, and this is due to them systemic vasodilators, so the nitric oxide, which reduces renal perfusion. If you've got reduced renal perfusion, it can result in kidney injury. Also, patients with liver cirrhosis tend to have problems with general anesthetic, because for one, they have altered metabolism, so they can't metabolize the anesthetic drugs. And also anesthesia reduces hepatic blood flow, and all of them factors can result in accumulation of drugs to a toxic level. So let's talk about the diagnosis of cirrhosis. So the gold standard is to do something called transient elastography, otherwise known as a fibroscan. So that's where a 50 megahertz wave is passed through the liver from a small transducer on the end of an ultrasound probe. And this measures the stiffness or the degree of fibrosis of the liver. And this could be done in patients with Hep C infection, men who drink over 50 units of alcohol a week, and women who drink over 35 units of alcohol per week. Patients diagnosed with alcohol-related liver disease too. Other investigations to consider is an OGD is an upper GI endoscopy, so they pass a camera down the esophagus and they can look in that region. It's on a new cirrhosis diagnosis to check for esophageal varices, so then dilated esophageal veins. Remember, because of the portosystemic shunts. Patients will also have a liver ultrasound every 6 months, plus a blood test for a substance called alpha fetal protein. Alpha fetal protein tends to be raised in hepatocellular carcinoma, liver cancer. So that's what happens in terms of monitoring for that too. And when we think about staging, tend to use the Child-Pugh score or the model for end-stage liver disease, or the MELD, which is known as the MELD score. The MELD score uses a combination of the patient's bilirubin, creatinine, and INR to predict survival. And essentially, these scores are predictors of severity and long-term mortality. So they have use in assessing severity and also the patient's cirrhosis prognosis. So let's talk about the management of cirrhosis. So the obvious one is to reduce alcohol intake. So we've mentioned that cirrhosis is irreversible scarring. However, reducing alcohol intake can improve long-term mortality. And then also we have options such as liver transplantation. This could be done in decompensated cirrhosis. Decompensated means acute deterioration in liver function, resulting in the features which I've previously mentioned, like ascites, jaundice, varices, which can hemorrhage, hepatopulmonary syndrome, and it goes on and on. And then also in compensated cirrhosis, particularly patients who develop hepatocellular carcinoma, and the need for liver transplantation can be decided by using a criteria called the Milan criteria. And patient might be eligible for transplantation if they have one lesion less than 5 centimeters or 3 lesions less than 3 centimeters, no vascular infiltration, no extrahepatic manifestations. But this also requires lifelong immunotherapy after the transplant to which there's very variable toleration between patients. Okay, and then other situations in which liver transplantation might be considered is in acute liver failure unrelated to cirrhosis, because today we've been particularly talking about how alcohol consumption can result in cirrhosis, but there's lots of other different factors. And also polycystic liver disease, which is related to polycystic kidney disease. And you want to remember that it tends to be autosomal dominant in adults and autosomal recessive in children. Okay, so that's everything for the video today. Next time, we're going to be discussing the complications of cirrhosis in more detail, and understanding about some of the different etiologies and also about the management of them particular complications. So that, like I said, that's everything for today. I hope you found that useful, and I'll see you next time.